For that, Dr. Rajeev Rao was selected, and we invite Dr. Rajeev Rao to give his oration. Dr. Rajeev Rao is working as a, please come over the station. Yes. He is working as a professor and head of the department at Jubilee Medical Mission Hospital in Thrissur. He graduated from Bikaner and did his MS from Jodhpur. After doing some work for some years in Rajasthan, he ultimately shifted to Kerala. He has been in the past also recipient of various inland fellowships of IOA, particularly Deputy Johnson one. He has been given awards during APOA, WOC, and AOS meetings also. We welcome you, Dr. Rajeev Rao.
Slides on. Good morning, respected chair, teachers, colleagues, dear friends, ladies and gentlemen. I'm thankful to IOA for giving me this opportunity to deliver the Silver Jubilee oration on a simplified axis which is around the ankle, the complex ankle which has been discussed from the morning itself by Dr. Taneja, Dr. Mittal. I'm just going to say about what is my study to introduce the same. I bring greetings from Kerala, where I work. This is the capital city of God's own country, Thrissur, and the hospital where I work. I dedicate this talk to my teachers, from where I learned my basic orthopedics 24 years ago, where they taught me orthopedics and made me to walk. And I just work on their principle of learning and trying to say about the simple axis of this complex ankle, which includes the TIBIO-TALAR and the TALO-CALCANEAL. Let me take you to a common example or a common condition which all of us over the time come and see and deal with. There is a fracture which has been at the level of the ankle. The talus comes out and it disrupts the ankle joint, and it also disrupts the subtalar joint where the calcaneum is lost its contact. We all go around by doing a simple solution, putting up a pin which gives us the maximum anatomical alignment of the calcaneum to the talus into the long axis of the tibia. Taking to another example where there is a open ankle fracture, subtalar joint has been disrupted, there is a fracture of the medial malleolus, the talus comes out of the situation and leading to a neurovascular structure damage. This was being stabilized by after debridement by a Steinman pin, which gives the maximum fixation with the minimal implant which has been used. This particular stabilization will help to let the plastic surgeon go across. Coming to another spoke wool injury around the ankle where there is fracture ankle with dislocation and subtalar as well as ankle dislocation. It's a simple problem commonly seen by all of us, and this was being ending up into some situation. I'm sure all of you would agree that it needs an ankle fusion because being an open, it was being just stabilized by a simple Steinman pin going across the calcaneum, the heel pad, into the long axis of the tibia. By seeing this, this is a simple example, simple method which has been doing it, but basic thing stands up. How do we align the tibia, the talus, and the calcaneum in one line? I'm sure all of you would like to avoid a situation like this, where the pin is trying to be addressed from the calcaneum into the talus, but it is misdirected. It has directed extra-articularly, or it has taken a different axial line in the same. I'm sure if you know the exact line to put this pin into place to let this common problem be targeted just like a bullseye, what Mr. Dhyan, in football, the hockey fellow who could do it, Dhyan Singh, could do is to put in a big football, a ground, put a hockey ball into a tire, which was his intention to targeting the same. So if we can target it perfectly, that was the reason. The biomechanical axis which we have been using over the years in THR, TKR, it stops up at the ankle and it extends to the second toe, which is what we have been using over the years. The fantastic eyeballing technique that we can pass a pin from the calcaneum into the talus, into tibia in the long axis is the ability of the surgeon over the time. but can this be reproduced by a young colleague? On this particular motto, we thought if this is to stop at this level and it extends into the frontal way, but there is no description of this axis going from the tibia into the talus, into the calcaneum in different planes, AP, lateral, posteromedial or medial views. So I intended to work on this so that we can go with more accuracy into the tibia in the long axis. With this particular interest, I started evaluating that can we find out those points, or can we describe an axis, or can we describe a line which will take up the ankle as a whole up to the foot and can align the tibia, calcaneum and the talus in one line in a plantigrade described foot. So we intended to start up our study to target that particular axis. The study was being intended to go for a proper direction aiming from the tibial long axis into the talus, into the calcaneum. So we set this as a TTC axis. We tried to make an anatomical study just before we could embark to the radiological part and combine it to the cadaveric studies. I would just like to take you that this study is intending only to be on a plantigrade foot in a neutral situation. So the anatomical study which said we try to make a long axis of the tibia which touches the posterior surface from the dome of the talus and goes all the way to the calcaneum. Where does it look from the medial aspect? We draw an imaginary vertical line. Try to go to the specific points on those that it touches the center, the long axis touches the center of the dome of the talus. It goes from the middle facet of the calcaneum. If you see the lateral view and the medial view, it passes from the angle of Gisane and it goes down to the earth in a normal plantigrade foot. We tried to make an observation that where does this axis go for? And this axis which we try to describe, try to make that can we describe this targeting from the calcaneum into the talus and into the calcaneum. This 3 is the complex which we often address, but the general validated science which says about TIBIO-TALAR and TALO-CALCANEAL. But to combine it all together, this goes to the long axis of the tibia, long axis goes to the dome of the talus, and from the middle facet of the calcaneum. This knowledge we thought we'll start up for the cadaveric part. For that we made certain protocol model that this would be our planning of mid-sagittal and mid-coronal study for a plantigrade ankle and a foot. With this, we tried to make all what has been in reality, taking ethical committee clearance, whatever the amputated limbs for diabetic other reasons were being taken up, 9 cadavers were being put for. We tried to mark the tibia long axis by putting up two K-wires in the mid-tibial axis in lateral as well as mid-sagittal and mid-coronal planes. After marking this, the bone was being sectioned and we wanted to see where these points look for. The mid-sagittal point of the long axis of the tibia touches the dome of the talus in the middle part. It goes through the angle of the Gisane at this point at the middle facet of the calcaneum. The coronal, mid-coronal sections of the long axis of the tibia again passes through the dome of the talus. It goes through the middle facet, but just lateral to the middle facet in the calcaneum was being point marked. We thought where would be if we combine the mid-sagittal and the mid-coronal planes, and the point was at the center of the dome of the talus, and this point was just lateral to the middle facet of the calcaneum at the articular surface at SUB-TALAR joint, which was being tried to make a radiological look by going through 2 X-rays which are being put at right angles. This is only depicting the 2 X-ray machines were being put at right angles on a platform. The ankle was stabilized in a wooden board and weight-bearing X-rays were being taken, and the line which was being drawn from the long axis of the tibia up to the ankle, and it goes to the second ray as we have been doing it for the same. Then we took non-weight bearing X-ray of 20 individuals where we could put the patient on an AP and a lateral view by taking a full length of the whole tibia and extend it into the second ray. Our observation was that there was 3 to 4 degree of dorsiflexion which happens on weight bearing should be neutralized, as we are operating on these patients in a supine or a lateral position, so weight bearing part has to be taken off. We extended this study to the modern gazettes and the CT plane, the long axis of the tibia to the second toe, and try to do this in AP views, in the lateral view, in postero-anterior view, as well as from medial-lateral views, and we saw this axis was passing what the reference point have been narrated till this. This passes through the long axis of the tibia to the dome of the talus, lateral to the middle facet in the calcaneum on the subtalar surface in mid-sagittal and mid-coronal points. With this, we thought that we can do the same part on an MRI. Probably it didn't give any extra information. The soft tissue part could be much more demarcated, and we did mid-sagittal and mid-coronal section studies. Combining with this particular idea, where were we? We had some variation of 2 to 5 degrees at the dome of the talus and 0.6 to 1.4 millimeters from the middle facet lateral to the angle of Giselle. That was the point which had been marked. Could we convert this study and combine that? We took our cadavers and tried to make a point of entry and saw them on the C-arm. This variation was insignificant because the Steinman pin used was 4.5. The variation of the alignment was being neglected because the width of the implant. This particular part, we thought we could do a much more targeting. Now we are very sure that if we target through this axis, we will go and reach to the bullseye. This particular thing which has been observed on C-arm, we tried to make our observation, can this be converted into a clinical practice? On the same cadavers, we tried to pass up a nail from the retrograde way, and we could anchor the nail in the same anatomical fashion what we depicted our Steinman pin could go. So this was giving us some situation where we had already embarked that we can go this by seeing an AP lateral or posterior view, whichever view. So there were being trying to make surface marking for the axis which we are designed, draw a long axis along the tibia which goes up to the second toe on a frontal view, but from the foot if you try to see, make a line from the second toe, go all the way to the bottom of the heel and divide this into 4 by 3 different transverse line at right angle. The junction between the frontal 3/4 and the posterior 1/4, if you try to hit an axis there, you will hit the target of the long axis of the tibia. This made us to go that we could embark on something. But before embarking, can this axis be of some use? I'm sure all of us, when I've been taught our postgraduate days, we talk about fracture ankles and the biomechanics. We talk about the position of the foot at the time of injury. We talk about the forces which are being acting. But our teachers have seldom told on which axis this act. Could we explain our ankle fractures on this basis? And I'm sure if you look into the vertical compression, the pylon type fractures when patient is loading on his or her ankle, probably on a fall, or when he is standing and rotating, or when the foot rotates, the body rotates, whichever way, the torque which would be combined. Can we explain that on this basis? We try to look that we could explain certain pylon fractures, the ankle fractures, all these can be explained on these principles. During postgraduate days, the Potts fracture, pylon fracture, all have been explained up in different names. But if you try to look into the anatomy, it is a fracture of the medial malleolus, lateral malleolus, posterior malleolus, the anterior or the lateral part. All these can be explained. If you try to visualize this, on this axis, the ankle rotating and breaking one after another, whether it is a different name can be given to this fracture because the inventor did it, we remember it, but I'm sure all of those can easily understand on the axis which can describe these fractures at a go. Coming to the clinical utility of this study, constraints of time, I'm not trying to put up the statistics. We use this axis for treating ankle fractures, treating arthrodesis on certain cases where we had managed CTVs, and I would like to let you go through the same. Whenever we talk about TTC axis, I'm dividing this into a distraction group where we distract the whole limb on the same plane, and whenever we distract it, we try to achieve a good anatomical reduction at the ankle with which we can go for a stable fixation, and followed by can an ankle soft tissue be well managed, and if this can be achieving, can it be done? Let me go through this particular principle, what we have been doing it over the year 1996 or to 86 or 46, whatsoever it may be. Fracture pylons were being treated in a way by putting up a calcaneal pin traction. And I'm sure today we put up an X-fix and wait for the skin wrinkling. Why this all worked up together? Why this all works? Probably the forces are acting on some axis to let it go through the same. Let me take you through the examples where you could see that a fracture ankle, pylon fracture, which has been managed with a poor skin condition on an external fixator. Elsewhere in the whole world, if it works on some axis. With this particular cases, the clinical utility of the TTC axial distraction in a comminuted fracture, which is compound, a poor skin condition, which has been distracted on an external fixator, passing a pin into the tibia, going all the way into the calcaneum, and the structures were being stabilized by minimal 2K wires, and the lateral fibular plating ends up with a good union at some point. Another case where C2 fracture with an intra-articular and a metaphyseal extension, where is a poor soft tissue, this all can be stretched on the same and let the fracture unite and wait for the distraction to be done. It heals up well. Coming to an A1 type with a gross edema where it could not be nailed up, this fragment could not be nailed, and this unnailable fragment was being put up by passing a pin from the tibia through the fracture fragment into the calcaneum, and this was being distracted and immobilized, followed by it went into for healing. Dear friends, I am sure by this axial distraction, any kind of fixation will hold if the principles of distraction or the biomechanics is being held. These are the X-rays which have been available to me and at my own, because there was no biological plates available when I started off this. But these simple implants can hold an ankle fracture to that level. Coming to the utility of this fracture, this TTC axial distraction versus axial stabilization, I'm sure all of you would do that, stabilize the ankle on its anatomical plane in a plantigrade foot. You had already seen this open fracture ankle, which has to need a stabilization where the plastic surgeon can come and give you a better ankle and a stable ankle. This is what has been done. A spoke wheel injury commonly encountered where there is an open fracture ankle, where the ankle was being stabilized by passing a pin from the calcaneum in the desired direction. Medial malleolus was stabilized, the lateral column was stabilized. This ankle has gone into for a very good healing at the end of 3 months. A spoke wheel injury where talus has come off the place, part of the talus is lost. After 86 months, the ankle has gone for a fusion, but it has been a plantigrade ankle where the person could go for work. A geriatric age problem, 87-year-old female patient who had to undergo a stabilization by passing up a pin, which has been done all the way. At this point of time, after 2 years, the nail has been removed, ankle is fairly stable of the lot. This was being done on an axial stabilization. Coming to the problem which has been commonly discussed and told is CTV from morning, we know. Probably I tried to convert this into a pediatric principle. If you could do so, we do a posteromedial soft tissue release. If you see the pins, there have been pin has been passed from the calcaneum into the tibia, into the talus, from the long axis. It maintains for 4 weeks. Once we remove the cast and mobilize the ankle joint, the whole anatomy is restored by a bony stabilization. This only holds for a temporary. Another rigid deformity, if you see this child who has got a vertical talus presenting at the age of 7, we stabilize this talus by making it horizontal and passing a TALO-CALCANEAL pin which is going all the way into the long axis and stabilize it for a 10 weeks period and later on. So deformities of the children can also be stabilized on the principles like this. An interesting case, 3-year-old child who had an absent fibula, an absent fifth ray, had an angular deformity of the tibia, and the parents came with the same thing. I tried to apply the principle where I corrected the equinus and angulation, stabilized the calcaneum under the tibia in the long axis, and if you see, after 7 years, this child who has undergone the surgery and could walk, his foot looks near normal, he could perform all his activities. He has an absent lateral ray. The same TTC principle could be applied for a compression because it's ultimately to get a normal plantigrade foot and ankle which would be helpful to walk for and restore the mobility of the patient. Let me go through certain examples. The spin is to be planned, which goes all the way from the calcaneum as desired after freshening up the surfaces of the talus and of the tibia, and a Charnley's compression clamp can be applied. Here is a case where it's a recurrence of the GCT. The talus has been eroded from the superior surface into the tibia, as well as the subtalar part has been involved. It was being fused by putting up a Steinman pin through the resection of the GCT of the talus, freshening up of the tibia and the calcaneum, and it was being fused. We achieved a stable, and patient has no recurrence for last 11 years. We quite often see open fracture of talus where talus has come out, it has been infected. We stabilize this talus by stabilize the ankle in a plantigrade foot and got for a fusion for this. Coming to the situations where this ankle could be going for a stable fixation, after the stable arthrodesis, the pin can be removed because it hurts to the patient. We do see certain flail ankles where patient had paraplegia, now have to walk because of lot of other modalities which can be done. They have a lot of equinus deformity. You resect out a wedge from the talus, try to realign the calcaneum and talus under surface of the, okay. Fix it up. So this equinus deformity at the ankle can be corrected by taking a wedge from the, I think it is on 47th slide. Yes. Good. And a resection of the wedge from the talus and foot was made plantigrade, followed by a stable fixation. Commonly discussed, a 36-year-old lady with a neglected clubfoot deformity had an ankle like this, and I'm sure what Dr. Taneja would love to do a procedure, or Dr. Mittal has already told you about that what can be done. Probably this was being stabilized on the same principle, anterior wedge was being taken up. Patient had first time walked on a plantigrade foot, and she was happy to share with her this photograph and her video. In spite of asking that we would like to do it, she said she would love to be there. With the same moment of energy, the patient said that she would be happy to share for a scientific cause. I conclude my talk that this TTC axis, the TIBIO-TALO-CALCANEAL axis, which could be used to help for the students to early understand what is the mechanism of the fracture, what way the medial lateral malleolus and the posterior malleolus can break, the vertical compression. It can be helpful for the teachers to explain how does this all happen. And I'm sure for the clinicians, this provides us a guideline of treatment. Can this be used as a part of axial distraction if you do it on the same plane. If this can be done for compression to achieve a stable fixation or any of those things for a busy clinicians. Yesterday, Dr. Tanna tried to show a very comminuted tibia and he stabilized and he said united with some amount of recurvatum. I'm sure this recurvatum can be avoided if this axis could be taken care. This particular axis can also be used for making this as a part of the result evaluation that how is ankle in AP plane and the lateral plane and in the posteriorly if you look into it. So this could be an axis which could say the index of acceptability for any fracture reduction, and it would help us to evaluate the plane of deformity correction also. I acknowledge this work to my team, to the surgical team whom I do work along, to my parents, to my friends who have been very much to stimulate my gray haunts to talk and think about this particular subject, and at the last, my wife. I thank you one and all.
Thank you, Dr. Rao. Kindly receive your award, which we have the pleasure of presenting to you on behalf of Indian Orthopedic Association.